Good evening, everybody. This is Dr. Rick Lehman in your corner with CORA. Today's date 7/15/2020, and we're still in the quagmire with the COVID. That is the third. Talk about that topic of shoulder replacements. And we have a guest tonight, Dr. Scott Zehnder, who has been kind enough to come on and talk about total shoulder for motion orthopedics here in St. Louis. So I'm going to have everybody introduce themselves as I always do. Dr. Zehnder, can you introduce yourself?
Yes, thank you, Dr. Lehman. Appreciate the offer to come and talk about total shoulder replacement. This is one of my favorite operations. My name is Scott Zehnder. I'm 8 years in practice now. Pretty much grew up in St. Louis, and I'm with Motion Orthopedics. I've been with them. I'm in my first year with them, but enjoying practice with them and doing. Seeing shoulder replacements as they come. So I'm looking forward to talking about them tonight.
Thank you. Dr. Zehnder's dad was a well-known standard orthopedic surgeon here in St. Louis. He was an excellent doctor, and I think led the way. Brandon, can you hear me?
Yes, sir, I can.
Brandon, that bow tie is killing me here. Go ahead, introduce everybody.
Hi, my name is Braden Martin. I'm a physical therapist here in Knoxville, Tennessee at our North Knoxville clinic. And I've been practicing as a physical therapist for a little under a year right now. Graduated last summer.
Great. And Kinsey?
I'm Kinsey Strauss. I work at the O'Fallon, Missouri clinic for CORA, and I've been out for 3 years now, practicing 3 years now.
Super. Mr. Allison, you're up.
Hi, I'm James Allison, Senior Clinic Manager of our Athens, Tennessee location. Been doing this for about a little over 3 years now.
That's awesome.
Appreciate you having me.
And everybody, thank you for coming on board. And we really appreciate your time. So we're going to start with Dr. Zehnder. Dr. Zehnder does a lot of total shoulder replacements. And I really appreciate his expertise for coming on. And I'm going to start actually with a kind of a tough question. You're in your clinic, a 45-year-old patient comes in, they have a retracted rotator cuff tear, there's not much arthritis. You know that you're not probably going to be able to repair the rotator cuff without tension. Dr. Zehnder, how are you going to treat that patient?
Yeah, those are some of the toughest patients to deal with. It's a huge dilemma when you have a young patient who, they're active, they want to use their shoulder, they want to do stuff, but the rotator cuff is unfortunately torn. Have they had any? Do we know it's irreparable just based on a prior attempt to fix it, or is it just based on MRI findings, or is it just kind of just based on the duration?
Well, both. I mean, either way. Maybe a failed attempt to fix it.
Yeah.
That'd probably be more likely. And it is a tough question. It's a very tough question. And the question then is that patient a candidate for reverse total, or
I think and if they're 45 and not a lot of arthritis, I talk about the reverse as it is an option, just because the reverse is that's our bailout for the irreversible for the irreparable rotator cuff tears. A newer option that's been kind of gaining some steam lately, though, is the Capsular Reconstruction, and I've done a few of these. That might, for someone who's 45, I think I might give that. I think that's worth some consideration for sure. That's a procedure where we're taking basically a piece of kind of dermal allograft. We're trying to basically stuff a piece of tissue where the rotator cuff would go. I view it as a rotator cuff reconstruction rather than a rotator cuff repair. But it does, what you're doing is you're anchoring tissue into the shoulder joint where the rotator cuff usually lives, but it's not a muscle in the sense that it functions like a rotator cuff. There's no muscle to really pull on it and make it work, but it's a pain relieving operation, and it kind of can help buy time in some of those younger patients where a reverse doesn't have a great track record. And if you can buy some time and get them some good pain relief and possibly some improved function, that's probably what I consider in that patient, and have that discussion with them. I don't think a reverse is the wrong idea though, because it's worth considering. Sometimes the supracapsular reconstruction, you know, if there's arthritis or if it fails, then reverse becomes your next option. But that's probably what I'd entertain most likely in that patient.
Thank you. I think that's a good discussion. Coming down the pike might be this balloon procedure they're doing in Europe where they put a little massive balloon, and basically all you're doing, like you said, is creating space.
They call it the shoulder boob. It's like a silicone breast implant that you put. Again, if you can just bring the humeral head down and get it off the acromion, I think that's where a lot of that pain's coming from. So a reverse does that, a supracapsular reconstruction does that, and theoretically, if you could put some sort of prosthesis in there, like a silicone implant, that would probably do the trick too. Interesting to see where that ends up going.
So segue to that is, tell me what your indications are. Who's a candidate for total shoulder and who's a candidate for a reverse total shoulder, and how do you separate those two patient populations?
Sure. Sometimes I don't know the answer to that till I'm actually in the operating room and looking at the rotator cuff. But when I see a patient in clinic, I tell them they have to be a candidate for surgery. So assuming they've already, you know, they're interested in total shoulder, I say they have to be a candidate for surgery clinically and radiographically. So radiographically means they got to show they have to have X-ray findings consistent with arthritis or irreparable rotator cuff. So they got to have a narrow joint space, missing cartilage, and I like it to be kind of that end stage disease where there's not a lot of hope left for that joint. And then I also say they got to be a patient or a candidate clinically, and this means they have to demonstrate pain. They got to be miserable. I like them to have failed conservative therapy. I think you're kind of setting the table for a good result. I think if you have a patient that comes in just because they have nasty looking X-rays, but they say they feel fine and they're tolerable and they're doing things and they're pretty happy with their function overall, maybe it's just some mild complaints. And if you just start operating on X-rays, I think you're going to get some unhappy patients. And I think if you have it the other way, where they've tried everything and they're still pretty miserable, but the X-rays don't really show a lot of damage, I think you got to be very cautious with that, because you got to look around at possibly some other pain generators. So for me, as long as you meet those two criteria, then we start talking seriously about being a candidate for a total or a reverse total shoulder arthroplasty. And then if it gets down to that, the total shoulder is where you're kind of recreating the patient's anatomy. You're replacing the ball with a metal ball, and you're replacing a socket with a plastic socket. In the reverse, you're doing just the opposite. And it sounds kind of crazy, but what you're trying to do is change the mechanics a little bit. But for me personally, I think the function of a total shoulder is better than a reverse, and I'd rather have that. But if you have a bad rotator cuff, then you're not going to be happy with your results. So this all hinges on the health of the rotator cuff. And sometimes it could be in question, and sometimes I really don't know until I get into the operating room and I actually like to feel the cuff myself. And sometimes I will prep the patient for a total or a reverse, and sometimes we make that decision intraoperatively, and I have both those sets ready to go.
Thank you. One quick question. Tell us a little about the function of the deltoid in somebody who's going to have a reverse total shoulder.
Yeah, so the deltoid is key. It is crucial to demonstrate a deltoid that works. And so we'll examine in clinic and kind of make sure that the axillary nerve, which is the nerve that innervates the deltoid, is functioning correctly. Make sure that the deltoid is is working properly. And sometimes if they've had a lot of previous surgery or an injury to the deltoid, then the reverse is not going to work nearly as well. And the reason for this is because with a reverse shoulder, a lot of the reasons we're doing a reverse shoulder on a patient is because the rotator cuff has been damaged and it's irreparable. It's no longer salvageable. We can't fix it. We've tried and it's failed. But what the reverse does is it changes the mechanics of the shoulder to basically allow the deltoid to be kind of your new rotator cuff. It makes the deltoid work a little bit more advantageously and possibly help improve your range of motion. So without a deltoid, if your rotator cuff's gone and the deltoid is damaged, and even if you have a rotator cuff, there's really nothing left to move that arm for you. So even though you have a fake joint, you're really going to have poor motion if you don't have a functioning deltoid.
Thank you. I think that was great. So Kinsey, Dr. Zehnder's just done his total shoulder. He's sending you the patient, and just a couple questions. One, when would you like to see the patient? How soon post-op do you think is reasonable to see the patient? Number two, give us just a synopsis of your post-op protocol. And then the one question that every patient's going to ask, Dr. Zehnder is going to ask you when they can start strengthening. So kind of want you to go through that for us.
Yeah, so first off, when we want to see them at first, as soon as possible. So as soon as you, as the surgeon, say it's safe to start moving it, to start beginning therapy, we want to see them, because even though they can't move it themselves necessarily for a little bit, we can passively stretch the shoulder. And the sooner we can do that, the less likelihood of them getting a stiff shoulder, losing motion. The more you wait and the more they kind of hold it in that sling position, the harder it is to get motion back. So we can start right away, just stretching it ourselves. That way they get full passive range of motion. And then leading into that next question, usually the kind of the timeline and everyone's a little bit different. But usually the first, 6 weeks or so, we're working on getting full passive range of motion back. Since they can't really move it themselves, we're working on getting full passive range of motion in all directions. And then usually about six weeks or so, we can start doing like more assistive active range of motion. So using pulleys, using canes, having things help them do the motion themselves. And then just kind of progressing to more active range of motion. So them lifting their arm on their own. And once they kind of progress to full active range of motion, we then can start to strengthen. Usually we start, I would say like 6 to 8 weeks, you can kind of start strengthening like isometrically. So not moving the shoulder with strengthening, but kind of just an isometric contraction, or like light scap, strengthening scapular, like postural stuff. And then once they have full active range of motion, I would say about 12 weeks, you can start getting into more of the shoulder strengthening and the harder scapular postural strengthening.
That was excellent. Thank you. Braden, this is going to be kind of a timely question, and a question that I think everybody wants to hear the answer to. And the question is, how has COVID impacted you and Brett and the people in Tennessee in terms of clinic? Are you seeing patients? How are you protecting the patients? How are you making sure that people aren't exposed in this pandemic that seems to not want to go away?
Yeah, so right now, a couple months ago, we started requiring all clinicians to wear masks when treating patients, and then all of our treatment tables inside of our clinics are spaced to allow for social distancing. That way, in case we still have a packed house, we're still getting those 6 feet away in between patients. And even when we're up on the floor, we keep in mind during our treatment plans to try to space patients out so they're not, face to face during the middle of treatment sessions. And then just recently here in Knox County, they made it a mandate that everybody inside of a public space has to wear a mask. So that has helped add, and we implemented that a little bit before Knox County did, that our patients are required to wear masks inside the clinic. And then basically anything a patient touches, from the equipment they're using to the door handles entering our clinic to the bathroom handles to the seats they sit on in the lobby, we wipe down as much as we can in between patients. That way there is as minimal as contact as possible. Along with this, we no longer have magazines or newspapers in our lobby areas. That way there's no spread of any germ or excessive human contact that way. And we're also, if a patient does arrive early, sometimes we will have them wait. If the lobby is busy, we will have them wait inside their car, and then we will come get them after that. Along with this, really, we're just keeping up with social distancing and keeping up with all the CDC guidelines and research that has been coming out, and just doing our best to implement that inside the clinic so people can stay safe and still get the treatment that they need and deserve inside of the clinics.
So when do you think it's reasonable to ask one of the clinicians or one of the patients to get COVID tested? Or are you doing any standard COVID testing? Or how would you decide, hey, one of the staff members, one of the clinicians needs to get COVID tested? What would be the indications for that?
So right now we are taking, all staff members are required to get their temperature taken every day. We take it at home. I take it at home before I come into work. And then every patient before they come into the clinic is required to sign their name and go through a COVID questionnaire that asks multiple questions about travel, and as well if they've experienced any fever or symptoms. And that is typically our rule out or rule in. And I believe our company policy is anything higher than 99.5. We require that a patient self-quarantines for 14 days. And we have had that happen once in our clinic. And fortunately, there was no issue there with the patient. There was no positive test. So she came back in, got well. But really, that's the deciding factor. And if they continue to have those flu-like and fever symptoms, then we typically suggest that they contact their primary care physician. And then they go from there and decide whether or not that they are suitable to be tested for COVID.
Awesome, thank you. Mr. Allison, what restrictions do you give your patients after a total shoulder or a reverse? And give us your idea what the hardest motion, what range of motion is going to be the hardest to regain. What are you going to have to work on, and what are you telling the patients early on? Hey, this is going to be the motion that's going to be the hardest to regain.
Typically starting out, after evaluating them, educating them on home exercise program, I always review the protocol from the physician as well. Everyone's is a little bit different, but typically right out of the gate, you're not going to want to actively lift or move that shoulder. So I emphasize the, just guarding it and babying it a little bit, keep ice on it for pain, but also doing your light stretches that you can do without, aching yourself too bad, focusing on coming into therapy and your passive motion and anything that you can do comfortably at home. As far as the most difficult motion, what we see is getting that arm behind your back, being able to tuck your shirt in, put a belt on, even just scratch your back. We see a lot of pain limitation there. And what you see with shoulders is because it's such a tight joint, inflammation and trauma from the surgery, everything hurts. And patients are very fearful of their pain a lot of times. So I'll educate them early on that, pain doesn't always mean harm. And just like pain-free doesn't always mean healed. But this pushing yourself to a little bit of discomfort to let the joint stretch out is okay, but we just don't want to push you into excruciation. I'll tell my patients, if you're stretching and you're calling out to Jesus, you're probably going too far. But getting realistic expectations that this might take a little bit longer than others, but as long as we focus on it and don't be too aggressive, it will come back and you'll be able to use your arm pretty functionally in that direction.
So when do you start your internal rotation stretching? Is that something to start right away, or do you wait a little bit, or how do you decide when you're going to start? You know you're going to have some problems with IR, with internal rotation, i.e. reaching behind your back, like you said. So when is a reasonable expectation to start your internal rotation exercises, and when's a reasonable expectation to tell a patient this is when you're going to get your internal rotation back?
Really just following the range of motion guidelines. If they're free to do any kind of passive stretching, I'm going to take them there. And again, just letting them know this might be the most uncomfortable. So just letting them kind of guide me symptomatically on what they feel. Typically around the 6-week mark when we expect most of the passive motion to be there. Again, if that's going to take a little bit longer, maybe we're looking at 8 weeks, but we'll continue to stretch that motion even once we get into active range of motion and strengthening. We're still keeping the joint mobile and continuing to work on flexibility. Typically, what I like to start with is extension of the shoulder. You need a little bit of the anterior stretch also to get that arm back there. So you can guide them, putting the arm to be able to at least clear their waist, and then you can start looking at elbow flexion to combine with the internal rotation of the joint to get that arm up the back.
Perfect, thank you. So Dr. Zehnder, a couple questions. Number one, most common question that I get asked, and I don't do total shoulders, and that is, how long can you expect a total shoulder to last? What's the life expectancy? And then number two, what can the patient expect in terms of function, and what's the range of motion, what's their strength parameters, what can they expect when they're done with their rehab after a total shoulder?
Yeah, that's those are great questions too. Definitely on that. I get that asked pretty much every time I'm talking about this. But and I tell patients sometimes getting, we're talking about the survival data of these total joints, and sometimes I think it's hard to get, when you're looking at the survival rates, you're looking at, if you want to know what 20-year survival is, you're looking at total shoulders you put in 20 years ago, and these implants are constantly improving. So a lot of these, a lot of the survival data were always kind of interesting to seeing if little tweaks we're doing are actually making a difference or not. But in general, I tend to quote that a total shoulder should last you between 15 and 20 years. Reverses theoretically might be a little bit less than that. There's a couple other things that might, make them, they're newer. They haven't been around as long as total shoulders. And so I think we're getting a lot of good 10-year data that shows about 90% of them are around at 10 years. That's one reason why if you got a really young patient, if start replacing their joints and they're 45 years old, sometimes they run out of options later on down the line. I sometimes tell patients getting a joint replacement is like dipping into your 401k. If you do it too early, you can kind of leave yourself with fewer options later on down the line. But it is a good, it's a great operation for pain relief. So yeah, in general, I think you can predictably expect between 15 and 20 years. The hope is always that if you're, if the average person's 65 when they get it done, the average person lives to be 85. Hopefully, you get that joint done, and the joint will tend to outlive you, and that's a good thing. In terms of the function, I think the anatomic total shoulders tend to have a little bit better range of motion than the reverse total shoulders. Most people should get around, I think, about 150 degrees average of flexion and abduction. A lot of it depends on how much range of motion they have going into surgery. If they have full motion going into surgery, they should get, a pretty good chunk of that back. If they show up with not a lot of, if their motion is very poor, sometimes it's less predictable. They're going to get nearly full range of motion. I tell patients the goal, especially with the reverse, is to get pain-free functional range of motion, which means if they're expecting to get 100, full abduction, full range of motion, and they want to throw baseballs and things like that, that's not realistic. Pain-free functional range of motion is at, at least 90 degrees of abduction and flexion, enough to comb your hair and feed yourself and tuck in your shirt. And if you can do that pain-free, some patients who show up with a lot of arthritis and a badly torn rotator cuff, their motion is awful. They're only able to get 30, 40 degrees. So if you get them, even if you get those patients up to 90 and they can, comb their hair for the first time, they're pretty pleased. But I do think that also is, the therapy is very important. If you do a perfect operation, but it's rehabbed incorrectly, you might not get satisfactory range of motion. So that's it's just the therapy, the rehab, and then also just being patient with it. Sometimes it can take up to a year to get all your range of motion back. I've had some people that are kind of frustrated early on, but as they stay with it and keep working at it, they'll get more motion.
And then why don't you, real quick, give us your post-op protocol, your PT protocol. What are you going to tell Kinsey? What do you allow when you start motion, when you start strengthening, etc.?
Yeah, so PT starts basically day one, and we'll start doing stuff with the elbow, wrist, and hand that you mentioned. There's always stuff to work on. I think that first day, you're right, things are a little dicey. They're a little sore, so we're not going to try and get all the motion back in the first day, but we can start working with the elbow, wrist, hand. I like to, my protocol is I usually will just do that kind of stuff for about 2 weeks, and then I see them back for the first post-operative visit, and then we'll start some formal PT and initiate passive range of motion. We need to be careful with the total shoulders, with the subscapularis. That's the rotator cuff muscle we have to take down, do the surgery, and then we repair it. And if we go a little crazy with the PT and we start to externally rotate someone, there's a risk that subscap repair will come apart, and then that patient's going to be in some trouble and have a poor result. So with 2 weeks, I'll start some passive range of motion with care taken not to externally rotate them, and then around the 6 week point is when I get them out of their sling and I start to allow them full active range of motion. The strengthening we want to be careful about. Usually around 2 months we'll start that, and then like I said, it can take once the subscap's pretty healed after 2 months and we start strengthening, then I'll let them really start going at it and trying to get that last bit of motion, and just telling them the whole process, between the strengthening and getting that last bit of motion can take somewhere between 6 to 12 months. That's awesome. The reverses, I forgot to mention this, the reverses, those you can rehab a little bit faster sometimes, because if you remember we talked about the reverse being a surgery for people who have no rotator cuff. So I do, whether or not you repair the subscap is the subscapularis is controversial. So I kind of do a half repair where I repair the upper portion of it. People who do repair it tend to keep their reverses in the sling a little bit longer. I kind of do a hybrid. Around 4 weeks, I'll get them out of the sling and get them start moving. So because you're not really worried about the subscap repair as much in the reverse.
That's excellent. So Kinsey, how are you going to protect? Someone comes in with a conventional total shoulder. How are you going to protect the rotator cuff? What are you telling the patient, and what are you doing that's protecting the subscap repair, which, as Dr. Zehnder said, is crucial. And if the subscap re-tears, that's kind of a nightmare. And how are you protecting the rotator cuff in terms of conventional total shoulder replacement?
Yeah, so a lot of times it's education at first. So, Dr. Zehnder will tell them to, where they're sling, don't move your arm. And they kind of come in sometimes and they're like, it's feeling pretty good after like 3 weeks. Like, I think I can start moving my shoulder. And so it's a lot of education. Like, even though it feels good, even though it's pain-free, you're still letting that subscap heal. You're still letting everything heal in there. And then usually we're getting a pretty specific protocol from the surgeons too, and it's kind of saying don't do any active external rotation, go to 130 degrees of flexion, just different range of motion limitations. So it's just about following that protocol, doing what you can in the windows when you can do them. So at first, kind of getting that motion back in the first 6 weeks within the limits of the range of motion limitations, and just a lot of education, just making sure they know how important it is at first to let everything heal and don't try to do the 6-month rehab in a 4-week span.
That's awesome. Braden, real quick, this is important. Is there anything prehab? Patient comes in, sees Dr. Zehnder. Dr. Zehnder says, look, we're going to put you on the schedule for a total shoulder. We're 6 weeks out or 8 weeks out. What are you going to do prehab wise? How can you get that patient best ready so they have the most beneficial result and the most efficient rehab after their surgery? What can you do prehab wise to get that patient ready to rock and roll?
I think the biggest thing, and Kinsey mentioned it already, is education. Truly, I feel like the best thing we can do for our patients is educate them beforehand on the whole process, the general timeline, and that timeline can fluctuate from patient to patient from time to time, and just educate them on where we expect them to be at certain guidelines, and really push them to work with us so we can meet those criteria week after week and month after month. That way we can get them back to where they need to be. Like Dr. Zehnder talked about, even if it's just functional for them, getting someone back to combing their hair for the first time that they haven't been able to in, years sometimes is wonderful. And it's wonderful to see that in the clinic. So really, from what I've seen, is just a whole lot of education for pre-op.
I like prehab. I mean, I think it's important on a number of levels. It's, insurance companies like you to try conservative treatment, and that kind of counts. So, so you kind of check that box. You're in B. And like I said, I think the more strength and range of motion you have going into surgery, I think the easier it'll be to get that back, because we know there's going to be loss of strength and motion, and that's everything to your result. And then C, it just helps you build good rapport with your physical therapist. And I think it can be frustrating when you see a patient, you do a surgery on them, and you're like, we're going to start physical therapy. And they're like, well, who do I see? What do I do? And, to have them already in there and kind of know their therapist and get ready to see them again. And it just makes that transition so smooth.
No, I
would agree with that.
Correct. Mr. Allison, last question. Patient comes in, had a total shoulder replacement, could be reversed, could be conventional. As we talked about, we're kind of nervous about external rotation, especially passive external rotation. Is there any other motions that you're going to counsel your patients to avoid? Reaching in the back seat, lifting in a certain way. What positions would make you, or what motions would make you the most nervous in terms of either damaging the rotator cuff, damaging the subscap, or somehow creating some notching or something in the shoulder that would be problematic?
Basically, it's getting that arm out away from your body. Anything that the elbow starts to elevate from your side, you're activating your rotator cuff, and educating the patient that rotator cuff essentially means rotation. So anything where your hand is and your elbow are rotating out away from your body, and educating them on the functional things that they don't even realize that rotation is occurring. Like you said, reaching into the back seat, scratching your ear, combing your hair, putting your hand behind your back, which seems so simple, can really risk affecting the rehabilitation of it. So sitting down early on and just really educating them that just because you're feeling good doesn't mean you can start, doing these things. Your arm actually weighs a lot, especially when your shoulder's up here, and the length of your arm is providing all this resistance in addition to gravity. Just being very thorough right out of the gate and reviewing protocol, and trying to get the patient as well informed as possible.
So, I want to thank everybody tonight. I mean, this was a really good discussion. And Dr. Zehnder, since you were instrumental, any closing thoughts, anything you want to tell our listeners out there, anything that we should know about future, etc. Closing thoughts, please.
I think, yes, I think collaboration with the physical therapist, I can't stress the importance of that enough. Like I said, I think a good physical therapist can kind of almost resurrect a bad surgery. And sometimes if I don't like the position of something, or if I've seen other patients who've had an injury, I'm like, how's your shoulder even functioning? And I think good rehab it's amazing how functional that can make someone. And it doesn't work the other way around. If you do a good surgery, but you don't rehab it, you're still not going to get a good result. So just stressing the importance of therapy. I think one of the most impressive studies about the effectiveness of physical therapy too is, just whether or not physical therapy works, a lot of times depends on, does the patient believe it's going to work? And so I think, good rapport with the physical therapist, and just having the surgeon, I just talk it up and talk about how it works good. And it's going to be completely instrumental. I think therapists the same way would agree with me on this. Sometimes you get these patients who, when you mention therapy, they're like, nah, I want surgery. And so just really selling them on the importance of the therapy, I think is crucial to their success.
Well, I agree with that. And I think communication, just kind of like you said, between the surgeon and the physical therapist is critical. I mean, it could be a text, a 1-minute phone call, but the patients really appreciate that you and the therapist are having a conversation and everyone's on the same page. So I really think that's correct. And I think you're right. I think that sometimes the therapists save us when maybe the surgery didn't come out exactly the way we might have expected it. So I think that's instrumental. Listen, everybody, thank you very much. This has been very, very informative. This is a great topic, very important surgery. It's a surgery that's going through some evolution with the advent of totals, reverses, et cetera, over the last 12, 15 years. And I think you're going to see some changes, some biologic changes as to progression in how orthoplasties are going to be done in the future. So again, everybody, thank you very much, and have a good night.